We'll be recording today's webinar because people will be inevitably asking if they can have a copy. There's some amazing information in this webinar today. And we're very pleased to welcome Kellen Baldock and Jonathan Lowe to share successes and lessons learned around Sunnybrook Health Sciences Center in Chairs for Meals intervention. Kellen is an occupational therapist who provides care to patients on the inpatient surgical oncology and complex malignant hematology units at Sunnybrook. He completed the 2018 to 2019 Toronto Academic Health Sciences Network Fellowship Program. And Jonathan is an occupational therapist in the Sunnybrook Veterans Center, as well as a performance improvement specialist on the Senior Friendly team. His quality improvement portfolio currently focuses on improving patient mobility at Sunnybrook. Before we get started, I'd like to let you know how to engage with our presenters today. As I mentioned, we'll be using the chat box for questions or comments, so please feel free to put your questions and comments in the chat box at any time, and we'll start our question period by 12:45. And with that, I'd like to present Kellen and Jonathan to take the stage, please. You may just need to take yourselves off mute.
Hello.
There we go.
Okay. Is our screen working, Wendy?
Everything looks good.
Okay. So welcome again. My name is Jonathan.
Oh, sorry, one moment. We need to switch over to share screen so we can see your slides.
Oh, am I not doing it? Okay. There. Better?
That's great. Perfect.
Okay. Sorry about that. So my name is Jonathan again.
Yeah, and this is Kellen.
And we just wanted to thank the RGP Toronto for inviting us to share with you about some of the work that's happening at Sunnybrook right now. And we're excited for what's happening, and we're also excited to hear from you about your experiences. And if you have any questions and comments, we'll do our best to answer them when we get to the end. So we just wanted to give you a brief outline of what we are planning to talk about today. So just going to share really briefly about why we're addressing mobility, why mobility is important in the hospital setting. And Kellen's going to share about his in-chair for meals project. So there's a little typo there. You only sit on one chair at a time, so in-chair for meals. And then I will share about what's happening at Sunnybrook and what we've got planned for the coming year, for what we want to do about patient mobility. And lastly, we'll share some lessons learned from what we've done over the past little while. So what's mobility got to do with the hospital stay? So we know in research that every day of immobility can lead to 1 to 5% loss of muscle strength in older individuals. And we see that the changing population at our hospitals now. Patients are getting older, they're coming in more complex. So we feel that it's important to start treating immobility as a hospital-acquired harm, and a harm that we can prevent or mitigate in many of our patients. And we have seen that patients that stay moving are more likely to maintain their baseline level of function and their level of care needs. And this lets us return patients to their home with the level of support that they had before more quickly. And we see there's evidence that immobility can increase the risk of a number of other significant hospital-acquired harms. So we keep our patients in bed. We expose them to higher risk of developing pressure injuries, higher risk of developing delirium, and it's also been associated with longer length of stay, and as they become deconditioned, even increasing the risk of falls. But why aren't our patients moving? So Brown and all, they did a study back in 2007, and they talked to patients who reported that they felt like healthcare providers don't see mobility as important, and also that our patients don't want to bug or impose upon our staff to help them mobilize. So we see there's a little dissonance between what we know is important and what we have been able to do and what our patients see as a priority. So patient mobility has been and still is an issue in the hospital setting today. And this isn't the first time we're talking about mobility. I'm sure if you have been in healthcare for a number of years, you've heard talk about mobility and the importance of mobility before. And at Sunnybrook, we started in 2012 with the MOVE program, where we introduced what we call the mobility ABCs as a way to categorize patient mobility, but levels of support that they need. And by instituting that language that gave our teams a common language to describe patient mobility to each other. And along with those levels, we have graded activity recommendations so that we have established a standard of mobility care for the patients that we see here. And as a third part of what we did back in 2012, we introduced the Healthy Stay Volunteer Program, and where we had volunteers come to units to encourage and assist patients to participate in some basic exercises and some basic orientation while they're here with us. So that's what we have done in the past, and we just wanted to get a sense from you, our audience, whether or not your hospital or organization has a patient mobility program in place right now. So we'll just give you a minute or so to answer, and then we'll close the poll and see what kind of responses we have. Okay, so from our poll, we see that 58% of our audience that has a patient mobility program in place at their hospital or organization. So just a little bit more than half, and 42% do not right now. So thanks for polling, and we have a couple of more polls for you later on. So stay awake, stay with us. So after we introduced the mobility language, our mobility standard, and our volunteer program, we saw pretty good compliance on our units through some visual audits that we did. And the reason that we do visual audits to get an idea of patient mobility is because it's kind of what we found to be the most feasible way to get snapshots of patient mobility at this time. And in an ideal world, we'd be able to track patients, slap a sensor on them, and just see how often they're getting out of bed, how well they're moving. And we see some technology emerging now that can do that, but we're not quite there yet. So for now, our best option is to send staff onto units, and we're looking at whether or not patients are sitting in bed, lying in bed, or whether they're sitting out of bed, in a chair, in a wheelchair, or even sitting at the side of the bed during mealtime. So we're looking at lunchtime here in our audits at Sunnybrook. So from 2012 to probably 2014, 15, we had pretty good compliance, but as we've talked to staff over the years, as we've done more visual audits, we found that there's been a decrease in patient mobility over time, and we recognize that there's probably a multitude of factors that have caused that. Shifting priorities at the hospital, shifting priorities put upon staff. We have, as we mentioned before, changing patient demographics. So a lot of good reasons why numbers may have slipped a bit. And last year we looked at one of our general medicine units. So this is a graph of the data we found there, and we found that we're really not getting great mobility of our patients up, at least at our meal times. And we totally recognize that our staff are getting patients up all throughout the day, but short of having somebody sit there on the unit all day observing people, we're just getting snapshots at some standard times for now. So that's our challenge, and maybe this is a familiar challenge to many of you. We used to have good energy around mobility for patients, but we want to recapture that. So how do we do that without any resources or any additional resources? When we looked at this problem again, we took time to look at some successes that we've seen in different hospitals and institutions. And we also wanted to look internally at some of the good work that some of our staff are doing, whether through fellowships or just other quality improvement projects here inside the walls of Sunnybrook. So just an example of some of the initiatives that we looked at, some of the programs that we've looked at externally. You might recognize some of these projects and logos. We looked at the HELP program, the Hospital Elder Life program. And this is a patient care program for older adults in the hospital aimed to prevent delirium and loss of function. So this program really uses volunteers to orient patients and keep patients mobile. And we're not able to implement the full program here at Sunnybrook, but we really recognize the importance of using our volunteers as a great resource to help our staff and our patients. And we wanted to make sure that we, as we revisit our program, that we use our volunteers better, that we increase the experience, we make the experience better for everybody involved. And in the middle here, you see the End PJ Paralysis logo, and you may have heard of that. And that is a global movement now that started from a grassroots campaign out of the NHS system in the UK. And what they wanted to do is encourage patients to get out of bed, get them dressed in their own clothes, and just to get them moving. And we really like that idea of reconnecting patients with their concept of their normal selves, what they used to do before they joined us here in the hospital, and how just getting them changed, getting them moving, doing the regular activities motivates them to do more and to move more. And lastly, we looked at the AMP program, the Activity and Mobility Promotion Program, developed by Johns Hopkins, where their focus is setting mobility goals, helping patients keep track, and working together with patients to achieve goals and go to the next level and keep moving while they're in the hospital. So these are just some of the mobility programs out there. If you know of any other great programs that you want to share, we invite you to just type them in the chat box. We'd be really excited to learn about what else is happening. And so this is a little bit of an intro about why we're looking at mobility again, what we've been doing at Sunnybrook, and how we're looking to expand our program. I'm going to invite Kellen to share more about his project, the In Chair for Meals project, that we thought was a good opportunity to take something that's happening in-house and adopt as part of a broader mobility program. So I'll turn it over to you.
Thanks, Jonathan. So, hi everyone. Again, my name is Kellen, and I'm a full-time frontline clinician. I'm an occupational therapist. I work across 2 units, a 36-bed unit and a 15-bed unit, one being a surgical unit. It's a surgical oncology unit, and the other, as was said, is a hematology unit. And so this project that I had the opportunity to work on was funded by a fellowship. It's a 6-month fellowship that provided me 2 days a week where I could, one, learn about what is quality improvement, how do you run a project, you know, developing each step along the way and helping to structure the project that I had presented or pitched for this fellowship. And then also time to do the work. As we all know, you know, we're increasingly stretched and feeling like we don't have time to engage in opportunities like this. So just really want to express my appreciation for the opportunity to do a fellowship and to do this work. So yeah, so the fellowship was 6 months, and it began for me in around October of 2018 and finished in 2019. The work that I initiated or that we as a team initiated during the fellowship has been ongoing, and I'm going to review the data with you as to what happened and where we got to and where we're continuing to go. Here. So I'm an occupational therapist, and my whole project really looked at one challenge, and that's aspiration. Not a natural connection, really. Aspiration isn't something that I think about previous to this project on a day-to-day, but hopefully I can make those connections for you and show you why I felt this was an appropriate project for me with my disciplinary background to come to. So a bit about aspiration. It can cause many complications like pneumonia, can become life-threatening if a person is unable to get enough oxygen due to blockage of the airway. And that can happen from putting food or liquid, taking that in, or it can be, you know, emesis or something coming out and creating some type of obstruction. Now, this project looked at the surgery floor that I work on. And our general surgery populations in general have many predisposing factors that put them at a high risk for aspiration, some of them being older age, decreased alertness, decreased mobility, and the list goes on. And so, when looking at the literature as well, it shows that aspiration is a frequent postoperative complication that accounts for about 1/3 of reintubations after abdominal surgery and carries a marked morbidity and mortality. Now, looking at our population at Sunnybrook, we found that there was this increase in the number of aspirations that we were seeing. And we actually had a few aspiration-related deaths in 2017. And so we decided this was an issue and we know aspiration is preventable. It's hard to track, it's hard to catch sometimes, but it is something that there are mechanisms to reduce the risk for patients. And so we came together, that's the surgeons, the entire interdisciplinary team, including dietitian, speech language, nursing, occupational therapy, physiotherapy. I'm missing a few, speech language pathology. We all came together just to see how can we address this problem? How can we reduce the risk for our patient population? So it's a detailed diagram or fishbone diagram that I have here. But really what I just wanted to show that, we came together to build out a root cause analysis, try to better understand what are the risk factors, what are happening, where do we think we can make make an impact. And so there were many different areas that we thought that would be contributing to increasing risk. And we're addressing this in many ways. And I'm just focusing on one initiative that we have ongoing. We have multiple interventions that are targeting different aspects of this diagram. But looking at data on aspiration prevention for postoperative patients, it's scarce. Like there's not a lot out there to guide us. However, many aspiration prevention guidelines from different area hospitals identify sitting upright during and after meals as a primary prevention measure. And that is supported by data. So, so we wanted to look at that. How can we increase safe positioning? And we wanted to specifically target meal times. How can we increase safe positioning and also inform patients? Or at least we wanted to also look at, are patients aware of the risk? This is a risk factor for patients that we're aware of, but this is something that we should make sure patients are aware of as well, and increase that awareness and what they can be doing to promote best practice, which is sitting upright during meals and 30 minutes post-meal. So I reviewed most of what on this slide, just it's outlining what I had indicated in the last slide. So I'm going to move on to a poll. So what we did from that step is we built out the root cause analysis, but we wanted to understand what's happening on the floor. What is happening in reality? Are patients getting up? And so what we did was in November of 2017, much prior to the fellowship, we did a 2-week audit, 7 days and 7 days, and we wanted to look at each mealtime, breakfast, lunch, and dinner, and we wanted to identify positioning. And we wanted to simplify this audit to say, are they in bed? Are they sitting up in a chair? Or are they at the edge of the bed? And we excluded anyone that was not being able to be witnessed at the time. And we tried to extend it for a period of time. So that was a couple walks around the unit and a visual scan of where is the patient. If they're off the floor for a test, and unfortunately, if they were off mobilizing, they're somewhere else, they're walking around, they wouldn't have been counted, but weren't counted in the total. So weren't impacting our numbers, but we knew that that was an outlier. And so just posing to the group another poll, what percentage of total opportunities do you think patients remained lying in bed? So I'll just give a minute here or so for responses, and then we'll look through the answers. Okay, the results are back. So the options were 25%, 40%, 55%, 70%, 85%. Now you're all very smart because you got the right answer. 52% and that's a total count of 30 people who are watching the webinar right now, voted for 70%, which is correct. With the second highest number being 85. So I think everyone's aware of the key message, which is patients stay in bed during meal times. And a lot of these surgery patients who are coming in for abdominal surgeries, in the case of my unit, are ambulatory. And so, you know, so that's something we wanted to look at. So yes, 7% of the time they remained in bed during meal times. So what we wanted to, so the picture there of our unit. So what we, and the beds are around the outside of this nursing station that I've taken a picture of. So what we wanted to do was look at these numbers, and we wanted to see if we could make an improvement. And so, you know, with the structure around quality improvement, setting a clear target, we wanted to improve our numbers by 30%, which is a bit confusing now in retrospect, thinking that you know, with 70%, it sounds like we wanted to get to a full 100%, but really we wanted to improve the count by a 30% improvement. And the goal was to do that by the end of that 6-month term. So first we did, you know, we identified our stakeholders and clarified our objectives. And that was to collaboratively develop an intervention or interventions with patients and staff that will increase the number of post-operative patients sitting in a chair at meal times, and to pilot the interventions on our unit. Recognizing that we had 3 buckets of stakeholders. We had patients and families, staff, volunteers. And so prior to these interventions, I'm showing you a bit early, we did patient surveys, staff surveys, we ran focus groups to help identify how best to support patients to be sitting in chairs for meal times. And what we recognized is what, you know, we knew, what I knew and what I think we all knew going in, is that how do we make an improvement with additional resources? And so what we really wanted to target was, say, we want to do an iterative process, introducing different interventions, but we knew they needed to be low resource, high impact. We knew we couldn't put a burden on only one, and it needed to be interprofessional. We couldn't just give this and hand this to one professional group and say, okay, we need to make this improvement, do it. And so our hope is one, recognize that patients can be partners in this as well, right? Patients, we can include them in what best practice recommendation is, and support them to also be engaged in their care and support what we're trying to move towards, which is reducing that risk of aspiration. And then also too, we recognize that of all the stakeholder groups, we had one group that were actually asking to be more involved with patient care, and that was volunteers. They recognized that, yes, we're involved and we are able to be engaged with patients, but we feel we could play a larger role. And so we said, okay, how can we tap into this group and get them involved in providing education and reinforcing the recommendations? And so we just, there's a bit of a Venn diagram there, identifying those 3 kind of buckets of stakeholders, and interventions, just identifying who were mostly involved in that intervention. So for example, there were 9 major interventions. I've only have a few here, but a few that were kind of our primary interventions, or at least the more intensive to put forward, were overhead mealtime announcements. So recognizing that we can give a lot of verbal education, but for, you know, some people don't learn that way. And how can we maximize our message and do it in multiple formats? So we engaged our patient support staff who are handing out the meals to do an overhead announcement about 10 minutes before meals, and just to indicate meals are about to be delivered. We encourage all patients to be up for their meals. If you need assistance to sit up, please use your call bell and request assistance, and staff will come assist. Some concern at the time was that maybe that would lead to an increase in the number of patients asking to get up. I think what we've seen over this period of time was it wasn't a huge uptick, but what we did know was that when we went around and audited to see if patients were getting the message, that was identified by patients along with some of these other interventions. So the message was getting to the patient. So that's being done, and it's continuing to be done. It's been a great intervention. One that actually, through these PDSA cycles, this was actually not something that came out from some brainstorming session away from staff. This came from a patient support staff said, this is maybe something that would be beneficial, and it's been one of our most successful interventions in terms of adherence and longevity. And so another one is bedside education posters. We had again, iterative design on building these out, patient involvement. There's 4 different versions with different patients. Here's a larger view of them. So here's 2 examples, but the messaging we knew needed to be clear. We got surgeons, again, all of the stakeholders were involved in informing the development of this, and it's in line with some of the media that's happening internally here at Sunnybrook. And in terms of them, we have 1 per patient bedside, ensuring, and we went around and made sure that at each patient bed, the patient was able to see at the time of when we were putting them up, that they were able to see, it was a large enough font, and that they could see the education that we were putting at bedside. So this is the tool that we built out, and this is where I was kind of tapping into my discipline as an occupational therapist. I thought, can we ingrain this in other work that we want to do, which is to say that, we are frequently using mobility to promote moving, and walking around, but mobility is so much more, and recognizing that people get up purposefully for different activities, like getting up to eat, like getting up to go to the bathroom, and how we can provide education around that and support to patients using our corporate level mobility, which we use ABC. And this was guidance and education that we were asking volunteers to learn and then be able to review with patients at bedside. On the back of this sheet is a tracking tool. Now, that was challenging to get patients to engage in, people not having pens, just with our length of stay not being too long. That was challenging, but we did hear some great feedback from the simplicity of the education and clarity, not only from patients, but from staff. And lastly, that was reinforced with staff, everyone getting lanyard cards. There were little placards on the computers, just reminding staff what that best practice recommendation is. And what we had heard is not everyone was fully aware of corporate level mobility. And so we just reinforced it. And I was able to work with Jonathan to help align with the work that's being done with our initiatives here and with Senior Friendly. So my next 4 slides are just reviewing the data. And so this is our findings over a long period of time. So we did these audits. Unfortunately, it wasn't too standardized, but what we did do was make sure that we did it over 2 days and few month intervals. And so I'll just orient you to the table here. The blue line at the top is the percentage of patients in bed. And so when we did an audit back from November to December, oh, it's moving on me. There we go. You'll see that it was quite high, and there's a general trend downwards. There was a peak closer to the end of my fellowship, unfortunately, in March, where we were actually on a C. difficile outbreak, and we found that had a huge impact on our mobility levels. But since that time, we have again seen a gradual decline in the number of patients remaining in bed, or at least the number of opportunities for patients remaining in bed during meal times. Now, the green line is our in chairs, which was our initial target. And the red line is patients sitting at the edge of the bed. And we wanted to really specify the edge of the bed because we recognize that's the transition between staying in bed to eat your meal and staying supine or lying down versus sitting all the way up into a chair. Recognize that that's that intermediary step, which is an improvement, right? It helps to get to our end goal, which is improving safe positioning. And I'll just review how we captured it again. So baseline data was collected with support from our interprofessional group, and all 3 meal times and other positions weren't captured, which I reviewed before. With interventions in place, there was a positive trend, and by our last audit, the rate was just shy of our aim of improving in-chair for meal rates by 30%. So, and then I've just broken it down further, recognizing that each meal had a different outcome, and the black line is indicating the TASN fellowship. We have been continuing to track since that time. And again, seeing positive trends. Our most improved meal was breakfast, which we were surprised at, thinking that the morning was the hardest time. Nursing are doing their vitals and having to orient to the patient, and that being a challenging time to ask them to be involved. But feedback we got back was also that's when they're at bedside and best able to help facilitate as needed and reinforce because they are, again, at bedside. Lunch was a challenging time. We did see fluctuation, and recognizing that there's other things going on. If they had an active morning, it may, and also delaying of meals when they were going to eat, that also probably had an impact. Dinner, we did see a positive trend, but they were higher numbers. So probably getting up out of bed was best in the morning and then worsened as the day went on. However, again, at each mealtime, we did see improvement. So that's the summary of the project work that I had done. We really wanted to focus on practical interventions that we could put in place that would best inform patients on best practice, not be burdensome, overly burdensome on staff, and be able to tap into resources that are asking, or we're at least identifying that they could play a larger role. I think nearing the end, we'll go through just a bit of challenges that went through the project, both for myself and Jonathan. So I'm just going to hand it back to Jonathan. Again, happy to take questions at the end of this webinar.
Okay, thanks, Kellen. So really what we want to do at a corporate level across our hospital is creating a new discourse about mobility for our staff, for our patients, for everybody involved in care here. And what we did was take elements from Kellen's In Chair for Meals project, and we wanted to emphasize getting patients up and involved in functional mobility. So another quick poll here. Hypothetically, if you talk to your frontline staff and ask them what hospital mobility is, what do you think they would say to you? And I know you probably know the best answer at this point of the webinar, but what do you think they would say? Okay, so 50%, so 30 of you said your frontline staff would probably say mobility is patients walking laps on the unit. And that is generally, I think, what we would assume is the message right now for most patients probably, and most many frontline staff, that if you're asking us to mobilize a patient, you're asking us to get them up walking around the unit. But we want to change that thinking. So in our work with the Senior Friendly team, we wanted to choose a few pilot units to test our interventions on. And one of our first steps was to complete a root cause analysis with one of our medicine units. And we talked to a number of our interprofessional staff and asked them to just think of barriers that they thought were in place that prevented them getting patients up as often as they wanted to. So there's a lot of information here, but the priorities that we wanted to target are highlighted in red, and a lot of them probably resonate with you. Staff don't necessarily prioritize mobility, and accordingly, patients don't necessarily see mobility as a priority either. And there's also barriers in terms of not having good access to equipment. Maybe there's not enough space in the patient rooms to easily get a patient up, or we don't know where the footrest for this wheelchair went, or my walker is missing a brake. So equipment is a big issue for sure. And something else interesting that we found was that staff sometimes find that there isn't a good way to communicate with each other about what level of support a patient needs to get up and move in, or they don't have a good way to collaborate, to plan, find a time that they can work together to get a patient up. So with that in mind, we really want patients and staff to think past doing laps when we ask them to mobilize. So with our work here at Sunnybrook, we want to roll out an idea called mobility moments, and we want staff to think about natural opportunities in a patient's day, or natural moments in their interaction with patients where they can incorporate mobility. So with my background in occupational therapy as well, and with what Kellen was doing in his project, we really thought these activities of daily living are really good opportunities for patients and staff to incorporate some mobility in their day. And we think that most patients would be able to participate in at least one of these activities independently, with assistance, or even just to get up to a chair with a mechanical assistance, but just to get out of bed. And we just want to give patients and staff as many ideas for simple ways to get people up and moving. So again, we looked at our stakeholders, and the same three stakeholder groups, our patients and families, our staff, and volunteers that are involved with our Healthy Stay Volunteer program. And what we did was we wanted to develop and collect some tools that we could bring to our units that have some standard and optional components. And we have things that we want units to implement to help keep things uniform, but we also recognize that units have different staff cultures, different types of patients, so different things will work for different units, but we want to bring options for our staff so that they feel like they are supported by us when we come to their units. But we also want to let staff and patients know that they're the experts in providing care. Our staff are experts in providing care to the patients, and the patients are experts in knowledge about themselves. So we want to take advantage of their knowledge, and we want to keep track of how things are going. So we want to get feedback from our stakeholders, our patients, our families, our staff, and our volunteers about the different things that we're testing out. And we recognize that as we roll out interventions on units, the things are always changing at the hospital. You heard Kellen refer to some things that are changing on his unit with outbreaks of different things, or sometimes there's just urgent priorities that pop up that might put our work to the wayside. But we want to encourage you, if you're involved in mobility work, to just keep at it, because we know that this is important work. So for our patients and families, our goal with the Up for Mobility work is to shift their thinking about and their understanding about why mobility is important as part of their healing journey. And I think something that we really see is that we want to make this message visible, and we want to reinforce this message to them in as many interactions as possible, because when we go in as clinical staff to see our patients, we go in to see them when we can, and our patients may not always be at their best. They might not retain all of the information that we're sharing with them. So we want to give them as many interactions with different staff, with different people, that reinforce this message to them. And we want to give patients the opportunity to set goals and for a way to keep track of their progress as a way to encourage them to move. So Kellen talked a little bit about this. The mobility goal tracker that we have tested out on some of our units, and that have, I think for certain types of patient populations works well, and for other patient populations may not work as well. If you have very high turnover, maybe it's a resource that it's difficult to implement or keep in place. But the idea is that we want patients to know how many times we expect them to move in a day, and according to our standard of care here, for patients that are able to move or walk or transfer independently or with assistance, we want them moving at least 3 times a day, which doesn't seem like a lot until you do it. So we want to be able to fill in that goal with them, and we want them to keep track of those times. And again, because we want to emphasize that mobility isn't just going for laps around the unit, I give them some suggestions about what other activities they can do that count as mobility, that might be a little bit more motivating for them to do. Like, you probably want to get to the toilet if you can, instead of using the urinal in bed. And we find that is encouraging for some patients, and for some patients they don't care. And we'll share some of the feedback, or I'll share some of the feedback I've gotten from some of the patients that have used this tool. But this tool we developed as a dry erase tool, so something that we can leave in the room. We have some whiteboards with patient information there already, so it just makes it a little bit easier, so that staff don't have to give out a printed sheet to every patient. But we also recognize that markers are also hard to keep in supply sometimes, so we give units the option to print them out as single-use sheets as well. And with the idea of keeping mobility front of mind, we created some placemats that can be placed on those bedside patient trays, just reiterating some of the education about why staying in bed is bad, what kinds of things patients can do to keep moving and get moving and keep moving. And we also have developed a website resource as another avenue for patients to educate themselves if they want. Maybe they want to just review some of the education that staff have provided, or they might want to just see some examples of how to move or what kind of activities they can do safely according to what they're able to do. So those are just some of our interventions geared towards patients and families. But for our staff, we want to reinforce their understanding of the preventative quality of mobility. So we want to, we know staff generally know that moving is good. We want patients moving, but we also want to get them excited about making these changes in their practice that can have positive effect on patients. So we made some tools, but we also created some campaigns that we're quite excited about that are going to come up soon. So, and then as we mentioned with staff, there's always competing priorities. So we wanted to take as many opportunities to partner with existing groups, existing interventions that might be happening. So in November, we partnered with our falls prevention group to talk about safe mobility with proper footwear, just to get patients moving. And that's one of the examples of things that we're trying to do. And you see the mobility algorithm lanyard cards that Kellen talked about earlier. So one of our campaigns is the Up for Mobility campaign, where we're asking patients and staff and volunteers to think about what kinds of small changes they can make in their daily work, in their daily interactions with each other that can increase patient mobility. So what we did was take this question to different interprofessional groups, asking them to think about their daily work, because we want to minimize the idea that we are asking you to do way more than what you're already doing. So for example, if you are let's say if you're a social worker and your work is to talk to patients, interview patients, how can you incorporate a little bit of mobility in your practice? You could, instead of asking patients to conduct the interview with you while they're in bed, encourage them to sit up in a chair while you have the interview. Or if you are a nurse, maybe instead of facilitating patients to use a urinal, you encourage them to get up to the bathroom or get up to the commode and incorporate a little bit more movement into their day. Or if you are maybe your chaplain and you're here to chat with a patient, if they're able to get up into a wheelchair, perhaps you can encourage them to get up into the wheelchair and you can go for a walk while you talk, instead of just having a conversation at the bedside with them in bed. So we're really asking our staff to think about what they do and how they could do things a little bit differently to have our patients move a little bit more, incorporate some more mobility moments in their day. And this campaign that we're going to be doing in March that we're really excited about is called the Mobility Madness campaign. So you might know the March Madness basketball tournament in the States for their college teams. So we're taking that idea of pitting units head-to-head against each other each week in kind of a tournament-style brackets, and asking them to count how many mobility moments or engagement in mobility moments that they're having with patients. So every education that they do, every actual mobility movement that they do, they can add a point to their score, and at the end of the week we compare between units until we'll have a champion unit at the end of the month. So what we really want to do there is to create a little bit healthy sense of competition. We want to highlight some success stories that can encourage other units, maybe some successful creative ideas that we could use on different units as well, and highlight some our high performing units to encourage our other units through this kind of competition. And then just for our volunteers, again, I spoke a little to this earlier, that we want to maximize the impact of this program. So we're looking at increasing how long a volunteer shift is and combining some shifts just to make sure that volunteers are able to see patients when they're most likely to be willing to work with them, and also looking at expanding the volunteer role so that they feel like they are an important part of our teams here, that they can do work that they recognize as important to the way that we are counting mobility. That way we're encouraging patients to move. And we've been tracking some of our work. So just briefly, because we're kind of running up to the end of the presentation here, you can see that we have some baseline stats from one of our medicine units. And as we tried out different interventions, we can see that the blue line are all patients out of bed data. With some of our interventions, there's a fluctuation, but things generally are trending upwards towards that green line where we're targeting for the specific unit. So just the idea, we want to reinforce that data is important, that we can bring back to our units to let them know how they're doing and to see what interventions are working and what aren't working as well. So we want to share with you now just some briefly lessons learned through our project work.
Hi there again, it's Kellen. Lots of lessons learned from the project. It was a great opportunity, but recognizing that getting out of bed for so many patients is challenging for a multitude of reasons. You know, if they're coming back and they're post-operative, they maybe haven't eaten yet, they have, decreased energy, significant amount of pain, maybe too many lines and tubes. The room is too cluttered, and I have fear and I don't want to fall. And throughout this whole process, we recognize that there are still so many environmental barriers. And so in that feedback piece, that's essentially what we got is, it's still hard, but yes, I know I've been told, which was really the goal, that patients are at least aware of what best practice is, because that's the first step. Is then patients are able to be engaged in their care and even advocate for what is best practice. Because if we don't have enough resources and patients are able to advocate that they need help, and then our team isn't able to meet that, I think that's much more leverage to say, okay, well, maybe there needs to be review of resources from higher level hospital administrators, just because that idea that there isn't enough resources is coming from the patients, which is ultimately what what we're working with, who we're working with, and why this work is so important. Also, the challenges, I would say multiple interventions have been ongoing and running great. One challenge has been just sustaining energy with our work with the volunteers, just because there is turnover, and recognizing that without protected time and being across multiple units, I find it challenging to provide guidance and support to ensure that work continues, given that I have returned full-time to clinical work. However, recognizing through this project, I was able to work with Jonathan, recognizing that patients getting out of bed is something that, related to aspiration is how I came to this, but obviously interested for so many other reasons why that's best for our patients. And so identifying like-minded individuals in the hospital who can work towards a similar goal is the way that I hoped that the project would continue to have legs and support, not only on my individual unit where the work was done, but on other units as well. And then some facilitators I printed off data regularly. I know right now at our hospital, we're reflecting out our hand hygiene numbers, and it's something that we're very aware of, and has been very motivating for units to work towards a best, what our target rate is. We don't have that hard data, given that most of our mobility is tracked by paper and pen. So it's challenging to have hard data all the time that you can gather, and it's so labor intensive to do these visual audits. But while we were during the fellowship, it was motivating for the team to be like, our numbers are down, okay, what can we do? What do we change? And people are involved in that way. So I found that was a facilitator. So if you can reflect back to your stakeholders to say, this is where we're at, I found that engaging, or at least was supportive of the work that we were doing. And then again, relationship and stakeholder buy-in. You need everyone to work towards this goal and recognize why it's important. So a lot of the time was spent to do that.
And just some lessons learned from the broader project here. I think patients recognize, once they hear about why mobility is important, they recognize and they appreciate that staff and the hospital are looking at how to get them more involved in mobility and trying to support them in that endeavor. And some things that Kellen already alluded to, there's always changes happening on units, there's competing priorities, and we recognize there's limited bandwidth for staff time and attention. So some things that work well, just really ironing out a simple but meaningful goal or meaningful ask for patients and our staff. What we're asking you to do, how much work does it involve, how much time we're asking of you, and this is how we can support you in this project work. And we want to use our campaigns to build enthusiasm and also use them as opportunities to recognize when our staff are creative, when they're working well, when they're really taking in our message and sharing with our patients. I mean, it always works well, as Kellen just talked about, just partnering with like-minded individuals, partnering with other groups that are doing similar things that relate. So partnering, for example, with the falls prevention group. And I think what we found works well is also coming ready with some solutions, but also being flexible and being open to ideas from staff on the unit or even patients when they have ideas for how we can improve things. So I think Wendy has opened up the questions. I think I saw some Q&A submissions as well. So
great. Thank you so much, Kellen and Jonathan, for sharing your expertise around these important initiatives. The chat box is open and we've got questions coming in already. So let's get to some of the questions. There are some questions around volunteers. So one is, what's an expanded role for volunteers, what that might look like? And somebody else was asking if there's certain criteria that volunteers follow in terms of which patients they can get up for meals, and do they actually provide hands-on assistance for transfers?
Yeah, sure, great questions. So with our volunteer group, they're not able to provide hands-on assistance. What the typical routine is now is they come on the unit, they go to they've already been identified as a person to go to, and I think it varies on units. On ours, it's our team leader who will review the patient list and identify those that are appropriate. Typically they'll want to offer an opportunity to move with someone who is independent. If someone needs assistance, they may just be engaged in other ways, whether it's providing an opportunity to be social, and maybe someone needs some cognitive stimulation. So I think that role is expanding on our side, recognizing that there are still limitations in the role that they can play from that physical assist. And then within the terms of the project, volunteers, the hope is that they, giving people visuals, saying things overhead, people learn in different ways. And nursing was identifying, and other staff members identifying, that we don't have the time to spend to sit and give this specific education. We have so many other things that we need to prioritize. And so the hope was that volunteers, after being trained around the tool, could sit with patients and review the tool and provide answers. And where they felt was outside, if it was outside their scope, that's when they can engage other staff to fill in with that additional education. So volunteers are aware of those who are independent to move, and then they mobilize with them and then offer other types of support for those that need an additional level of assistance.
Yeah, and just to add on to that a little bit, so I mean, in addition to giving them an opportunity to engage patients and providing education, we're also going to be asking volunteers to help us with those visual audits. So those things that take time, that staff don't necessarily have regular time to do, we want to build it into what our volunteers are doing. They're going to be on the unit around at least the lunch meal time, so they have the opportunity to go around, speak to patients, but also see whether patients are in bed, out of bed, and with them providing data that's important to our teams in terms of tracking how we're doing. Hopefully that gives volunteers a sense that they're really contributing a really important part to the mobility work that's happening at the hospital.
Great. Lots more questions and comments coming in. One is around staffing ratio, and there's some comments around nurses, of course, being very busy and there's time constraints, but I think you answered some of the questions around using volunteers and patients and family as part of that whole plan. But I wonder if you might be able to answer the staffing ratio question.
And sorry, just to clarify, is the question around what is our staffing ratio for nursing?
The question was just, what's your staffing ratio? So,
Sure.
yeah.
So on the surgical unit, the 36-bed unit that I work on, it's 4-to-1. So 4 patients to 1 nurse.
Okay. Another question came in about falls rates, wondering if there was any data around that, especially when around the audit times for out of bed.
We haven't had the opportunity to compare that data with our falls group. I mean, definitely with our partnership in November, we wanted to see if our falls rates decreased, if our mobility rates increased, but we haven't quite had the chance to review that data yet. But that's definitely something that we want to see. And I have, read in literature that, oftentimes we think that getting patients out of bed increases risk of falls because they're moving. There's an opportunity for them to fall, but they found that there isn't really a strong correlation to keeping patients active and the number of falls rates compared to keeping somebody in bed in that sense.
Right. There's a question from an SLP wondering how much involvement you had from SLPs for the project.
Yeah, great question. So I had mentioned earlier that this was when we were looking at that fishbone diagram. This was only one area for aspiration, and recognizing. I'm going to answer I'm seeing the box now. I'll answer this question at the end as well around the outcome measure. So we recognize that aspiration, yes, it's high morbidity mortality, but the number of instances over the period of time wasn't enough to really give us a change over time for this project. So the way we structured it was to say that because we know that improved positioning is positive for reducing the risk of aspiration, our goal was just to improve the number. We still measured, but because it's because the frequency isn't high enough, it wasn't great to use as an outcome measure. It was more, I forget the terminology, but it was an outside measure. It wasn't the focus of the project, just because we knew we wouldn't see change over time at least in the scope of the project, which was only 6 months. And sorry, back to the SLP. So our speech language pathologist was heavily involved in other areas primarily, still providing, I remember getting feedback just saying that this was now education that she was providing when she was at bedside. But she's been, quite instrumental in developing our risk screen tool, which is being used on our unit to help identify at-risk patients and escalate care when needed to the physician group. So that's a project that's ongoing and instrumental. So definitely it's been interprofessional throughout. I think different areas have different focuses for people, but has been involved. And then we met quite regularly, I think every other month. So was always involved in the project as well.
Great, thanks for that. Now, there are a few more questions coming in, but unfortunately we're up at the end of the hour, and I know that you graciously provided your email contact, so I'm assuming that you might take a few questions by email if people have really pressing questions for you after the webinar.
Yes, that would be great.
Great. So thanks again so much for this great learning opportunity and for sharing all that you've done and all that you've learned. We want to thank attendees as well for attending, and you'll receive a short evaluation survey by email. So please share your suggestions and topics for future webinars.
Sorry, Wendy.
Yes.
We provide that? Were they able to see those emails, or should we be providing, they can see it now?
It was on the deck, and we'll send them out by email too. No problem.
Oh, great.
Yeah. We wanted to quickly highlight one great resource that's been recently launched, and we hope every webinar attendee will share with caregivers of older adults with frailty the Caregiving Strategies resources, which comprise online course, handbook, and website. And they were developed by the RGPs of Ontario with caregivers and healthcare providers as co-creators. And there is some great information on mobility in there as well. There's registration open for an online course which runs from February 3rd to March 30th, and we'll circulate a flyer to all attendees as well to spread the word. One final thing, we'd like to invite you to our next webinar, which is coming up on February 28th. It's entitled Specialized Geriatric Services Decision-Making Tool with Kelly Milnes, the presenter, and he's the director of the Regional Geriatric Program of Eastern Ontario. And registration information will be sent out by email as well soon. So thank you again to both of our presenters, and thank you to our attendees. For signing off now.